Good Friday morning, everybody. Good morning. Excellent. It is my great honor to welcome you all to the 16th Annual James E. Clyburn Health Equity Lecture on a subject that is timely as it is critical. I am Tara Sabo-Atwood, Dean of the Arnold School of Public Health, and this is my very first Clyburn Lecture. I began my role in August of last year, but I actually started my faculty career in the Arnold School nearly 2 decades ago, and it feels great to be back home. On behalf of the entire Arnold School of Public Health, I extend a warm greeting to our distinguished guests, most notably Representative James Clyburn, whom we are honored to have with us today, and our keynote speaker, Dr. Keshia Pollack-Porter. I also welcome our campus and community partners and the faculty, staff, students, and alumni who are here today. This lecture series has become a hallmark event and is a point of pride for the Arnold School and the university. I especially want to recognize all of those who have worked so hard to make this event a reality. Special thanks to the faculty and staff of our Department of Health Services Policy and Management, led by Dr. Brad Wright. Thanks also to the members of the Planning Committee and to our sponsors, all of whom are listed in the event program. We are truly fortunate to have this lecture supported by Representative Clyburn, a genuine and longtime champion of public health and the well-being of underserved communities. Representative Clyburn's leadership has been instrumental in addressing health disparities both in South Carolina and across the nation. His commitment to improving health outcomes for all individuals, especially those who have been historically marginalized, aligns deeply with the mission of the Arnold School. Health disparities are not just a statistical issue, they are human issues affecting lives in profound ways. Whether we're looking at chronic disease, access to care, or social determinants of health, the gaps we see in our state and region are a reflection of systemic inequities that must be addressed. These are challenges that impact communities around the nation, but they are especially notable in South Carolina. We are pleased to have experts and thought leaders in the field join us today to contribute their knowledge and perspectives on this important topic. Our keynote speakers focus on advancing health equity through health in all policies will offer us all the opportunity to expand our thinking about a comprehensive approach to addressing the inequities that exist in health. We are also fortunate to hear remarks shortly from Dr. Edward Simmer, Interim Director of the South Carolina Department of Health. Dr. Simmer is a valued friend of the Arnold School and a true champion of public health in his own right, and we are grateful for both his service to our state and for his presence here today. It is my hope that our collective engagement at this event will help to further the conversation and spark innovative ideas as to how we, as public health professionals and community members, can work together to tackle the persistent challenge of inequities in health. Once again, thank you all for being here. I look forward to the enriching perspectives that will be shared today and the collective strides that we will make towards a healthier, more equitable future for all. I now invite Dr. Tony Torres-McGahee, Associate Dean for Access and Collective Engagement in the Arnold School, to come to the podium to introduce Dr. Simmer.
Good morning and welcome. It is my pleasure this morning and honor to introduce Dr. Edward Simmers. Dr. Simmers is the Interim Director of South Carolina Department of Public Health. In his role, he leads the cabinet agency and reports to Governor Henry McMaster. Prior to being named the interim director, Dr. Simmer was appointed as the Director of South Carolina Department of Health and Environmental Control. In the role at DHEC, Dr. Simmers led a team of 4,000 dedicated professionals in the areas of public health, healthcare quality, and environmental control. He oversaw the state's response to COVID-19 and Mpox, led the agency's response to 2 hurricanes, and ensured the state's health care facilities provided quality and safe care. He led all of the state's over 70 health departments and worked to improve the health of the people of South Carolina and the environment in which they live. Before being confirmed as the agency director at DHEC, Dr. Simmers served over 30 years on active duty in the United States Navy, where he held other leadership positions that included Chief Medical Officer and Deputy Director of TRICARE Health Plan, and Commanding Officer and CEO of the Naval Hospital in Oak Harbor, Washington. He has led over 25 years of extensive clinical leadership and team building experiences with a strong track record of transforming large healthcare systems. He's received his Doctorate of Medicine degree from St. Louis University and holds a Master's of Public Health degree with a focus on epidemiology from Eastern Virginia Medical School and Old Dominion University Consortium, as well as a bachelor's degree from Hiram College, and he's completed his psychiatry residency at the Naval Medical Center. Dr. Simmers is a board certified in general and forensic psychiatry by the American Board of Psychiatry and Neurology, and is certified in administrative psychiatry by the American Psychiatric Association. Welcome, Dr. Simmers.
Well, good morning, everyone. Well, it's great to be here. Thank you for that amazing introduction. Now I have to live up with that, I guess. But let me just say, first of all, how much we appreciate Dean Sabo Atwood. Your arrival has been great for public health in South Carolina. Very glad you're here, and appreciate our relationship and the way we're working together. Thank you. And Representative Clyburn, you have been a great supporter of public health, arranged a number of events for us, sir. Thank you for all the support that you continue to give us as well. We appreciate that. And thank you to the committee for inviting me here today and giving me a couple minutes to speak, and I promise it will be a couple minutes. Since taking the director role in 2021 and having the opportunity to work with many of you and many of our partners, I've made it my priority to always have a people-first approach to everything we do, because I find that when we put people first, everything else falls into place. For those who don't know, the Department of Public Health is almost brand new. We were created on July 1st, 2024, out of what was the Department of Health and Environmental Control. And we are the health part of DHEC. And I think we've gotten off to a good start over the first 9 months, but we still have a lot more to do. For 50 years prior to then, our predecessor, DHEC, made significant strides in promoting and protecting the health of South Carolinians. And we're proud to continue this legacy under our new banner, and our commitment to serving the people of South Carolina remains steadfast as we move forward. Because together, we work to serve as champions for the people of our state by protecting and improving the health and quality of life for every South Carolinian. And that is our goal, to reach every South Carolinian, no matter where they're at, no matter their status. Now, as we move forward as an agency, there's 3 things that I'm hoping to focus on. First of all, as we all know, we need to rebuild trust in public health. That's just the way it is. And I think we do that most effectively by listening to the people we serve. So one of the things that our agency is now actively working on is markedly increasing our outreach and engagement efforts. We're reaching out to every faith-based group in the state that we can find, every community group, local governments, and others who may have an interest in this area. And and instead of telling them, hey, DPH has this great program, you should try it. We used to do that a lot, and it didn't work very well. So now what we're doing is we're saying, what challenges do you see for your community? What problems do you see from a health standpoint? And we define that very broadly, that your community needs assistance with. And then we say, let's try to help you overcome those challenges. Sometimes that may be things that DPH does, but many times it's going to be us linking them with another resource in the community that can help. So I really see our role moving forward, still doing things, of course, but also being a convener that brings people together to help. I think that's going to be very important. A second thing we're very focused on is the health and safety, healthcare and safety of our healthcare facilities, which we're responsible for, and improving that, making that more transparent. And then also identifying what are the core functions of public health. What does the Department of Public Health have to do for the state of South Carolina, for the people of South Carolina? And let's focus our resources and our efforts in those areas so that and prioritize those, so we're putting the taxpayers' dollars where they will do the most good. And especially in a time like this when we know that we're having some reductions in funding, that's going to be critical. Now, we all know that there's a lot of health disparities in South Carolina. And I'm probably not telling you anything you don't know when I say that if you look at the latest maternal mortality report, that moms in rural areas are twice as likely to die while pregnant or during the year after childbirth. African American women are more than 2 times as likely to die. And those numbers are unacceptable. Black infants are 3 times as likely to die as white infants in this state in the first year of life. More than 1% of black infants do not see their first birthday. That's terrible. We can't accept that. 29203, a zip code that's about 2 miles from here. It's about a mile from my office. Has one of the highest rates of diabetic amputations, not just in the state, but in the nation. And the rate's almost double there in that zip code what it is for the state. Why? Lack of access to good health care, lack of knowledge about how to manage the diabetes, often lack of knowledge they even have diabetes. Because if you don't have a health care provider, and many folks don't have access to a health care provider there, it's a problem. So we're working very closely with that community, with the leaders in that community, to address those problems, to help get access, to help do education. Working with a number of faith-based groups in Columbia and West Columbia on diabetes education, on looking for diabetes early. So if you have pre-diabetes or you have early diabetes, we can intervene so you never get to the point of that amputation. Very important. From the maternal health standpoint, we have gotten funding from the legislature for a mobile maternity health unit, the first publicly funded one in the country. And that unit, when we get it, which we hope will be next year, is going to go around to those underserved communities, those counties where less than half the women get adequate prenatal care. And we have several counties like that right now. We have 15 counties with no OBGYN, another 5 with only 1. That's almost half the counties in our state. So this mobile unit is going to go in those counties, go to places, and help women get prenatal care. It'll have an OB, it'll have a nurse, it'll have a doula, it'll have an ultrasound, all the things you need for pre and postnatal care. It'll provide mental health and substance use screenings, because that's one of the top reasons moms die in that first year after the child's born. We have to address that. And so that's how, when we see a lack of access to care, we try to make sure there is that access. So that's what we're working on. Now, it's important that we continue to organize thoughtful community efforts by removing barriers to improving the health of the people of South Carolina and fostering conditions in which people of all ages can thrive. And that's more than just providing health care. Providing access to health care is important. But I think you're going to hear from our keynote speaker, I'm guessing a little bit, but I think so. You're going to hear a little bit about social drivers of health. And that's something that we're very focused on. Because access to care is great. But what if the doctor tells you, you need to get out and exercise more, and you've got nowhere to go and do that? There's a poster out here that I encourage you to look at. I think it's number 3, maybe, that talks about walkability and what predicts walkability in the neighborhood. Very important. Is there a place that you can do those sorts of things? Do people have social connections? One of the reasons I think we have such a high rate of medical problems in our elderly population is they're not socially connected. They're stuck at home. We need places they can get out, interact with other people. That's incredibly important to people's not only mental health, but physical health. We need to make sure that people have transportation. I told you that 15 counties without an OB. We have moms that have to drive 50, 100 miles to get prenatal care today. What if they don't have a car? What do? We don't have a good answer for that, and we're working on that, but because we need a good answer for that. And all of this, again, can't be done by DPH. We are working to increase collaboration through active conversations with a variety of partner organizations all across our state to develop plans to determine the best strategies and leverage available resources. Our efforts are including every county in this state. We have a health department, at least one in every county, total of 76 sites all across our state. And we have staff in each of those health departments now that are going out and doing this very important work. We are actively including community members in this process, because in the end, we need to listen, as I said. It all comes back to that. And, as we move forward, I look forward to working with all of you, because we need lots of partners in this effort. And that's why I'm so thrilled to be here today. So excited to see such a great group of people, all interested in advancing health equity, because I will tell you, despite the controversies about that term, health equity is still one of the 5 fundamental goals for the Department of Public Health, and it's going to stay there. Because we know that we're not, thank you. Because we can't improve the health of South Carolinians without that. Crucial point. I've been talking a lot. If you look at the America's Health Rankings that have been coming out every year since 1990, South Carolina has consistently been below 40. I mean, we're one of the 10 worst states. A lot of times we're in the bottom 5, right? That's bad. Last year we were 39. This year we're 37. We are making progress. Is 37 good enough? Absolutely not. I've told our staff, our goal is to be the healthiest state in the nation. Right? Now, I will tell you, I had one person tell me, Doc, so long as there's barbecue and all the other good things you can eat in this state, we might not get there. Got it, but we're going to try. So, our goal is to make this the healthiest nation in the state. But what I am so encouraged about and really excited about is we are making progress. 37 doesn't sound great, but it's a whole lot better than 45. So I look forward to taking this journey with you. And as we move forward, we recognize that we must continue to work. Our vision is healthy people living in healthy communities, and I'm convinced that working together, we're going to make that happen. So again, thank you, and I look forward to a great seminar.
Good morning, everybody. My name is Brad Wright, and I am professor and chair of the Department of Health Services Policy and Management in the Arnold School. Today, I have the privilege of introducing our keynote speaker for the 16th Annual James E. Clyburn Health Equity Lecture, Dr. Keshia Pollack Porter. Dr. Pollack Porter is a Bloomberg Centennial professor and the Bloomberg Centennial chair of the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health, where she also serves as director of the school's Institute for Health and Social Policy. Dr. Pollack Porter is an internationally recognized health equity scholar whose research advances policies that create safe and healthy environments where people live, work, play, and travel. Her scholarship emphasizes identifying policy solutions that address structural drivers and social determinants of health, and promoting effective cross-sector collaborations to reduce disparities and advance health equity. To that end, she spends a considerable amount of time directly engaging with policymakers to promote evidence-informed policy decisions and advance health in all policies at the local, state, and federal levels. Indeed, Dr. Pollack Porter's passion and tenacity to engage with and inform decision makers in the science of how policies can impact health, along with her talent to build partnerships and create change, make her a standard bearer in the public health arena. As you can read for yourself in the program, Dr. Pollack Porter has published over 200 articles and received numerous accolades during her career, including being elected a member of the National Academy of Medicine in 2023. She's also committed to paying it forward to the next generation. Since 2019, Dr. Pollack Porter has directed the Health Policy Research Scholars, a national program of the Robert Wood Johnson Foundation that trains doctoral students representing various disciplines as leaders in health policy who can advance health equity. Dr. Pollack Porter received her BA in sociology from Tufts University, her MPH in chronic disease epidemiology from the Yale School of Public Health, and her PhD in health policy from Johns Hopkins University. She also completed a postdoctoral fellowship in evaluation that was jointly sponsored by the University of Pennsylvania and the Robert Wood Johnson Foundation before she joined the faculty at the Bloomberg School. Today, she will be presenting her lecture entitled Advancing Health Equity Through Health in All Policies. And against the backdrop of what I'll call a rapidly evolving health policy landscape, which I think is probably admittedly the understatement of the century, I'm incredibly excited to hear from her today. So without further ado, please join me in welcoming Dr. Pollack Porter.
Good morning, everyone. Thank you for responding. Because I would have said it again if you had not, so thank you. It's so good to be here. It's a Friday, it's a great day. I flew in from Baltimore late last night. I bring you greetings from Baltimore, where it is not as humid as it is here, but I love the warm weather, so I appreciate it. It's also Basketball Friday. I'm a sports fan, so although I'm not doing well on my pools, but we're gonna shout out the women's team tonight, hoping for success there. And again, I'm so thrilled to be here. I want to just take a moment and thank Dean Sabo-Atwood. Thank you for having me. Thank you to Dr. Wright. Really appreciate your invitation. Thank you to the Planning Committee and the sponsors, and of course, Representative Clyburn for being the person who is honored through this lecture. So I appreciate everything you've done to advance health equity and public health in this country. So I am just excited to talk about an issue I care a lot about, and I'm gonna make sure I keep myself honest by keeping an eye on the time. So let me go ahead and get my little timer going. But I'm thrilled to talk with all of you today about how we can think about advancing health in all policies and advancing health equity by connecting with other sectors to lift up health in policies. So I just want to ask a question before I get started. Has anybody heard of health in all policies before? If you give me a little hand raise. Okay. And for those of you who have not, I hope that by the time I finish, you'll be familiar with the new term and maybe a new way of thinking about health when you're engaging with other sectors. So in our time together today, I'm going to begin by just describing how policy can really help to advance health equity. I'll talk about health in all policies, or the acronym is actually HIAP. So when you hear me say HIAP, that's health in all policies. I'll provide some examples of how health in all policies can advance health equity and how we have seen the importance of working across sectors to make a difference. And then I'll talk about some ways to continue to advance HIAP and how you can think about doing that in your work. So I know I don't need to define health equity for this room, for this population, but one of the definitions that I've really come to appreciate in a simple way that resonates with people is one that I've become more familiar with since having the honor of being elected to the National Academies of Medicine, is thinking about health for every single person everywhere. Health for everyone everywhere. And that's one of the missions of the National Academies. And that really epitomizes the importance of reaching out to individuals. We just heard your comments about connecting with individuals in rural parts of the state. We can think about, in Maryland, where I'm from, our efforts to reach out to individuals in every single community in Baltimore and every single community in the state, regardless of where you were born, where you grew up, where you went to school. So health for everyone, everywhere. And I believe it's possible to get there. I believe that the vision of having a healthy nation, of having health, optimal health for every single person is possible. I'm sure you've seen images visualizing health equity, and I wanted to get us all on the same page for today. This is an image from the Robert Wood Johnson Foundation, and I appreciate this one. If you haven't seen it before, it's reminding us of the differences between equality and equity. Equality is important and essential, and it's different from equity. And so if you see this image on the left, it's showing equality. And it's, as somebody who started doing my work in built environment and physical activity, I really resonate with this image, where we have it for individuals who are stepping off of a sidewalk or need to cross the street. And every person has the same exact setting. But we know it doesn't work for everybody. We see individuals in this image. We see a child, we see somebody in a wheelchair, somebody with a cane, and they all need to cross the street. But if you look at the image on the right, which really epitomizes equity, we see an environment that gives everybody what they need. So there's a slope for the person in the wheelchair, there's sound for somebody who we assume is hard of hearing, it's easier for the person with the cane and mobility challenges to get across the street. And by embracing health equity, we are saying, where is everybody starting from? And how are we addressing the environment to make sure that we meet everybody from where they are, taking into account their context, their circumstances, and their conditions. And this is a mindset shift for many people, right? Centering equity, being intentional about equity, and we can be intentional when we work with our partners in other sectors to think about bringing equity into decisions and into policies and programs.
So how do we achieve health equity? And I'm intentional with using the word achieve here because I do, again, think it's possible. Well, I know that we can work upstream as opposed to downstream, right? As public health individuals, we can think about the parable of the stream and the kids that were falling into the stream, and we can move upstream and help to prevent people from getting hurt, getting sick, falling into that river in that upstream parable. We also can address those structural drivers of health or the social determinants of health and those root causes. I grew up at a time where health equity wasn't the thing that we were talking about. We were talking about health disparities. It was before the language was really common as it is now. And we would see the disparities. I started doing work in cardiovascular disease and looking at differences, particularly amongst older adults and comparing older Black adults to other races. And we would see these differences, and really it was about identifying the why. What was it about the upstream factors, about the structural drivers, about the social determinants that really caused those disparities? That's where we need to continue to focus our efforts. I also think it's critical to center community. How are we, I love this, the vision that you laid out of going to talk to people, engaging community, hearing from them, listening to them, centering them, sharing power with community, sharing resources. Those are strategies that we know can help to advance health equity. Promoting civic engagement. I'm a policy person. When I was a doctoral student, I worked on staff for a state elected official where I got to see how state policymaking works and how it happens. And I think promoting civic engagement and the voice of people to be part of the policy process in whatever way they can is also an important way to help to achieve health equity. And finally, changing those dominant narratives, rebuilding trust in public health, helping people understand the value of investing upstream and in structural drivers of health, changing the narrative about why it's important to work together. I believe that these are all important strategies that collectively can help us get to a place where health is possible for every single person everywhere. And finally, changing policies and systems. Again, and if we do that, we can address those upstream factors, and I'll present some examples of how we're actually operationalizing that. Because you might be thinking, Keshia, this sounds great, but how do we do it? Well, I hope by the time I finish today, I'll share with you a few ways that my team and I are doing this in Maryland and in some other states. So as I said earlier, I'm a policy person. I chair Department of Health Policy and Management. My master's was in epidemiology, and I tell people I'm an epidemiologist turned policy maker. I appreciate epidemiology, and I remember when I was, just as an aside, applying for doctoral programs, I spoke to someone and I said, I want to make a difference in public health, and how do I make a difference? And they said, go learn policy. Again, nothing against any other discipline within public health, but it was an emphasis and a reminder of the importance of policy and how policies impact our lives every single day. And policies made by people for people, whether that's public policy or policies at a store where you want to return something, we all are affected by policy. And I believe and have seen examples, and as I continue to engage with elders who I can learn from or look at other examples in history of this country and around the world, we see how policies can change systems and improve society, which leaves me hopeful for the future, knowing that policies that we change now can help to achieve that goal of health equity. We also know that changing policies or new policies can often change people's minds and attitudes. We've seen how the public has embraced ideas through policy change. We've also seen the opposite, but I also believe that there is a way to bring people on board in what we do in terms of moving and advancing policies and changing policies for the better. And finally, there are plenty of examples where we've seen changing policies be a path for permanent social change and really helping to drive long-term systems reform. This is an image, I'll talk through it if you can't see it in the back, from a paper that we wrote about policy, and I just want to ground us today. This was a paper that wrote several years ago about the importance of policy change for advancing public health. And this image just reminds us of the various types of policy. So when I talk about policy, I'm not only talking about legislation, but we also can think about the importance of regulation, the importance of thinking about federal, state, local policy. You know, after the 2016 election where there was a lot of concerns or fear about what was going to happen at the federal level, some colleagues and I wrote a paper called Go Local, reminding us of the importance of local policy to impact people's lives. So I want to remind you that policy at the federal level is critical, as well as policies at the state and local and regional levels, as well as institutional levels, where you work, where you go to school. All of these policies we can think about leaning into to help to address and advance health equity. In that paper, we also laid out 4 principles for effective public health policy change: using evidence to inform policy, conducting good research, translating that research, communicating it to inform policy change, considering health equity, and I'll come back to that in a moment. We also proposed designing policy with implementation in mind. So thinking about how is that actual law gonna be turned into practice on the ground? And then finally, using research policy translation strategies. So working with policymakers, asking them, what kinds of research do you need the answer to in order to inform your work? This is something I do regularly. And it informs the types of questions that I ask and the types of work that we're generating and translating and sharing back with policymakers. So I wanted to shift and lift up the importance of multiple sectors influencing health. And this is an image from the National Academy's, one of their reports on the structural or social determinants of health. And I'm showing this image to remind us all of the importance of various sectors in influencing health outcomes. So what we see in this image is in the middle, it just talks about different values, making health a shared value, focusing on health equity. But I want you to look at that circle around the colors in the middle. And what we see there are highlights of various sectors. So we see transportation, we see built environment, we see housing, we see public safety. I'm sure you all can think of policies or decisions in all of these sectors that impact our health. Think about education and school meals, right? So where kids eating meals in schools, that's about health. Think about public safety. Think about housing, transportation. All of these areas, these sectors, our decisions are coming out of them that impact our health. So as public health people, I think we need to work closely with these other sectors. Because ultimately, by not doing that, we have a problem. And that problem, from the way I see it, is that decisions made in these sectors can harm health and not support health. But that leaves us with an opportunity to engage and work closely in partnership with these other sectors. And that means approaching those relationships with deep humility, with questions, by listening and understanding the processes, the constraints, and the resources that our colleagues in other sectors are working in. I started to do my work with the transportation sector, and as somebody who had studied transportation and active transportation, I knew nothing about how policy change worked in the transportation sector, particularly at the state and local level. It's not as always, you look outside, you think, oh, that road is easy to make a change to. Sometimes the local community the local health department, transportation department doesn't even own that road. So we can't make that change there. We have to ask whose jurisdiction, who's responsible, and how do we work with those individuals and understand their goals? And I believe it's possible in the work we do in public health. So I do a lot of work in an area called Health in All Policies. Again, HIAP is the acronym. And just to make sure we're all on the same page when we talk about health in all policies, because this just isn't rhetoric. This is actually a way of approaching societal decisions. So health in all policies is a collaborative approach. It's about bringing together our health partners with our non-health partners and coming together to look at evidence, to make decisions grounded in data, and to change the way we operate. So it's about systems level change. And it's about addressing those structural determinants of health, those social determinants of health. So let me give you an example. In Baltimore, many years ago, the local health commissioner started something called a CAT team, which was the Cross Health Agency Task Force. And she brought together individuals from the health department, from every other agency in the city, so housing, the Board of Education, Public Works, et cetera, came together and they would talk regularly about what was happening in your sector. What decisions do you have coming up? And the health department would say, well, as you think about that decision to redesign X or to bring in Y. Let's think about how we can promote health and not harm health. So being intentional about bringing together these sectors, this is one way we have seen this type of strategy operationalized. And health in all policies has actually been around for many decades, very popular outside of the US in particular. And really we've seen leadership coming out of Canada, coming out of Europe, where there are laws that say this is the way decisions need to happen. This is the way that we need to promote society working together across sectors, getting out of our silos. And we've seen impacts on people's lives. We've seen changes. And again, there's some of this happening in the US, but I think there's tremendous opportunity to embrace these strategies more and more in communities at the local, state, and federal levels. So there are a number of tools to achieve health in all policies. I won't list them all, but here are a few of them. But one thing to know is that a health in all policies lens or framework is really flexible. There's no single way to quote unquote do health in all policies. You can have a cross-sector or cross-government task force like I mentioned in Baltimore. You can integrate health considerations into planning processes. So for example, when a zoning code, for example, is being updated, think about how you can integrate health into that. Zoning plans govern how we think about using land. Even thinking about alcohol outlets. This was a project we did in Baltimore. Our zoning code actually mentions density of alcohol outlets. Talk about health impacts. That's now in the code. There was considerations of that when we did that analysis. We also see opportunities to bring health-related scoring criteria when we're scoring grants. And then finally, an area that I do a lot of my work in is around using tools like health and impact assessments, so HIAs. I teach a course at Hopkins on HIA. I've been doing that for about 15 years. And we're teaching students how to do this type of policy analysis to understand how health can be improved and not harmed through policies. And I'm going to define HIA and tell you a little bit about it, so just follow me on this journey because we're going to go back to health in all policies in a moment. But just again to make sure we're all on the same page, if you're unfamiliar with health impact assessment, it's a way, it's a process, it's a method, it's a tool to look at the potential ways that health can be impacted when there's a proposal. So this is an evaluation. Here's a proposal. Before that decision is made, let's think about how health can be impacted. So we do that analysis and we share those findings with the policymaker to inform the decision. So this process is actually very common and is used, again, outside of the US regularly in some places. One of my colleagues who I brought into my class this year lives in the UK, and there's consulting companies that do these analysis all the time. And so here in the US, there are a number of individuals who do this work. There was actually a whole group that was at the Pew Charitable Trust promoting and expanding use of health impact assessments across the country. And let me just say that this is not an academic exercise. The goal is to inform decisions and make better decisions in non-health sectors. In terms of HIA, this figure shows the process, by and large, that a health impact assessment goes through in terms of generating the outputs that we're interested in. And I want to just say this process can be as succinct as just being done in about a week or two and more of a rapid health impact assessment, all the way through to a more comprehensive. I worked on an HIA for about 2 years once of a big federal bill. But we also can do this in a very rapid way at the local level. There's a whole field of rapid health impact assessments. And so again, I just show you this to say there are steps, there are formal steps, and if you want to learn more about health impact assessments, I want to direct you to this website, communitycommons.org. I'll leave it up so you take a photo of it. You can go onto this website and search for health impact assessments by sectors, by level of decisions. You can see what these look like. You can understand them and see how they're done. Find ones that have been done here in South Carolina and inform yourself about how we're working with other sectors to bring health into these decisions. So this is one tool. And as much as HIAs, I think, are very useful, they're not always the right tool for every decision, particularly when we think about policy. So some colleagues and I looked a few years ago to figure out how often HIAs have been applied to policy proposals. And quite frankly, when we look at them, we see that there is potential to make policies more health sensitive. We can think about HIAs informing policy development or implementation. We can think about how if we are intentional with bringing health into the proposal development process, we can advance health equity. We also can think about engaging various decision makers to ensure that the research in this analysis responds to what they want to know. And we also see opportunities when we do this type of analysis in an HIA to consider the social, political, and economic context. So a lot of potential here. However, there's limited application of HIA for policy. Well, why? It sounds great, right? But it's not happening all the time because of the challenges with the policy process. Right? Policy is not linear. It's not from X to Y. There's a lot of different things that happen along the way. We can see that at the federal level, at the state level, at the local level. We also know that policy making is impacted by a number of factors. As much as I want to believe that evidence alone causes change, we know that there's a lot of other things that come into play. We also know that some people don't think that health is sufficient enough against these other factors to really drive change. Right? It's the politics of it all. I remember when I worked for this elected official, he had said, if you want to change policy, you have to understand the politics. And that was why he made me march in parades, work on campaigns, before I even got into the office to start working on policy. We also know that timing of doing a health impact assessment, even though it's a flexible tool, can be challenging for short legislative sessions. In Maryland, our sessions are 90 days long. So in 90 days, all the bills for the entire state are moved forward, have to cross both sides of the chambers, cross over. It's not a lot of time. You know, we do these analysis, we might have a week or two before the hearing is set for the bill to do this analysis, to then share it, and to inform the decision. So not a lot of time. We also hear lots of questions about uncertainty with the HIA predictions. Remember I said an HIA is about saying what could happen. I had somebody tell me once, well, Keshia, did it happen? How do I know? We're making our best guess based on the best available evidence. And while we have done evaluations and gone back, we are asking people to believe us in terms of saying this is what could happen. And I acknowledge that uncertainty. And then finally, you might be more familiar with environmental impact assessments. That's really at the root of HIAs, and for a number of reasons I'm not going to go into today, EIAs tend to be politically charged, and so when people are promoting health impact assessments, some people think, well, those just like environmental impact assessments, and they're not as open to these. Again, acknowledging that challenge, but one that I believe is possible to overcome. So given this limited application of HIAs and my time in the state legislature, I said to a colleague now about 10 years ago, we need to create something else. And I was talking about how in Maryland we have fiscal notes that are created for bills. So there's an analysis of the fiscal impacts of a bill on the state, and I said we need something similar for health. And we came up with a legislative health note. At the time, it was initially, I called it a public health note, but over time it has evolved into being a legislative health note. And what this vision is to say, let's do these rapid analysis of the health impacts, and when you get a fiscal note on a bill, you're getting a health note as well. So I'll talk a bit about how we developed that, what we've learned, and where this is right now in the rest of our time today. So the vision for the health notes really, again, was driven by the fact that I was looking at bills through my time when I was working with that legislator as a student, and then when I later came back on faculty, looking at these fiscal notes and seeing, again, little appreciation for health. Now, I want to acknowledge my colleagues at this Maryland Health Department who were very much involved in the bills coming out of the health committees. But because of capacity, they couldn't look at all the bills coming out of every single committee when you might have 3,000 bills proposed in a session. And so what we thought about was there was an opportunity to look at the bills coming out of the non-health committees, but that clearly impacted health, right? Getting back to the social determinants of health I mentioned earlier. And so the goal of the health note and my vision was really to help policymakers identify the potential and often overlooked connections between those bills from non-health sectors and health in a way that was clear to understand, in a way that the analysis was done in the timeline to inform the decision. And we thought, well, if a bill didn't move forward one session, the findings could be used between sessions to maybe even inform the bill. Now, I'm not a bill drafter, that's not my job, but I thought we had a real opportunity to come in and to provide sound evidence to help to inform the decisions that were being made in these other sectors. We also thought that there was a way for these notes to help the public better understand how these other bills could impact health. And that might be through hearings, or that might be by working with community partners to disseminate these findings, to help people understand that bills coming out of the Environmental Matters Committee, or the Judiciary Committee, or the Education Committee could also impact health. And finally, we thought that these legislative health notes could also help to highlight the potential impacts of that bill on health equity. And so we decided to really be intentional about lifting up health equity in all of these notes that we create. So we developed these health notes through a really formative research. We listened to a lot of people, had lots of conversations, and did a couple of studies. One, in looking to see what was out there, we actually found out that Washington State had a process that was the closest thing to what I was imagining. And they have something called health impact reviews. And so, of course, as any good researcher does, we went and researched that process to understand, spent a lot of time in Washington State talking to legislators, community members to understand the health impact review process. We evaluated that, we published this paper on it to help people understand how they were using health impact reviews to address health disparities. That was the charge in the legislation that governs this. And we also did our own work. At the time, I was working with the Health Impact Project, which is a collaboration of the Robert Wood Johnson Foundation and Pew Charitable Trust, to study health impact assessment related tools. And so we worked with some individuals at the National Conference of State Legislatures and really tried to understand the potential to create a legislative health note. And part of this comprehensive formative work was really to understand what was out there. We didn't want to duplicate anything, and we wanted to see how we could add to what was already being done. And we saw a clear gap, which really generated our further thinking about what we needed to create. So after we created the health note, we then had a pilot, and this pilot was supported by Robert Wood Johnson Foundation and Pew, and we put out actually a notice to a number of colleagues to partner with states or localities to build capacity for health notes. We also came up with this process to say, well, once our team could help you with the health notes, we would provide technical assistance, and then how do we sustain it? How does this go forward without our work? We also sought organizations and community groups and agencies that actually had the capacity to screen the legislation and to do the analysis. Because one thing that was very clear is that those of us who are from public health understand these connections between these non-health areas and public health in a way that people who aren't trained in public health don't fully appreciate. So we had to do a lot of education to help people understand. And I remember we would go to different places and talk to legislators or staffers about health and about health notes, and they were like, yes, I get it, healthcare really matters. I'm like, yes, and. Healthcare matters, and so do these other sectors. When we started our pilot, we decided to focus on 4 sectors: education, labor and employment, housing, and land use planning. And we started with those 4 because we thought that there was a preponderance of evidence showing how decisions in those sectors could impact health, both positively and negatively. And we also thought that the data in these 4 areas were available to the public, by and large. And I'll come back to that point in a moment, something we learned during our pilot. We released this report under the banner of the Health Impact Project. We summarized our pilot, really focusing again on different states and localities to help consider health and policy making. And we ended up, and I'll tell you a little bit about our pilot in a second, but we also published a methodology guide. And you can find this online, you can Google this. We have made it very transparent how to replicate and do this own analysis in your states. A goal was not to keep this for ourselves. We've written the peer review paper, but this report is available online. Just do a search for this and you can find it. So you'll see in that report that what we do is pretty straightforward. We read the bill, we do a policy analysis, and break down what are all the ways that that bill component can impact health. The direct impacts, the indirect impacts, and the health outcomes. And what we do is we do a rapid analysis of the literature to figure out all of those pathways and what does the evidence say for each of them. And we look for local data on the context to bring that into the analysis so that it is clear how these data can apply and impact the community that's at the subject of the bill, whether it's the state or whether it's a locality. In terms of the structure, I just laid out the pieces. We have the facts of the bill, the goal of the note, and then we essentially have the analysis. And you might be thinking, Keshia, this looks really long. It's not. We really focused on making it as brief as possible. We have since added a brief executive summary at the front of these because that's all people want to read anyway, but then they can go to the rest of the document for the methods and the additional focus. One thing I'm proud of is that for every single health note, we find subject matter experts to provide a review to make sure and hold us accountable that we're not missing something out there. So I'll tell you a little bit about our initial pilot, which was from 2018 through 2022. And so we started in working with partners in Indiana and Colorado. And we started with those two states because we wanted a diversity of political perspectives. We also wanted to work with legislatures who had pretty solid relationships with academic partners who could do these analysis. And so we had some funding that we gave to folks in our academic partners in Indiana and Colorado. We also partnered with the Center on Budget and Policy Priorities and worked with 3 states that they had been working with that were policy shops but not doing health policy. So we trained them, because they already knew how to do policy analysis, we just trained them on how to bring health into their work. So we did that in California, North Carolina, and Ohio. We held a convening, December 2019, I just think of pre-pandemic, but together in person. And then after that, some local individuals in Washington, D.C. at the City Council heard about what we were doing, and they reached out and said, can we partner with you all as well? So we started to apply our pilot at the local level. So in that time, we completed 22 legislative health notes, and I say who's we, it's primarily our team who was at the Health Impact Project, and we are funded to do this. So we were telling people, we can do this for you for free. Let us come help and work with you. And then, of course, we evaluated our experience. In terms of the evaluation, we hired some partners to conduct interviews with legislators, staffers, subject matter experts, anybody who touched these notes that we created. And they ended up conducting these interviews and analyzed the qualitative data. And let me tell you a little bit about what we learned. So there's a paper out there that we actually just came out with last year. Somebody from my team is the lead author on that, Kerrigan. And we showed that people felt like this was a really important way to advance health and all policies, that the legislative health note could generate information to help bring health into considerations that we wouldn't really think of in these non-health sectors. We also learned that people thought that the health note was nonpartisan, it was very clear, it was objective, and it was very easy to understand. So it was written in a way that provided the evidence, but also described the evidence in a way that was clear. And I should say, with the evidence, we also rated the strength of the evidence. So we would say really strong associations about this, or lack of evidence on this, to be transparent about what we know and what we don't know based on the available evidence. And very transparent about our methods, so that people would know what we were doing was credible and well-referenced. We also heard from a few individuals that they thought the level of detail, how much we went into in the health note, was appropriate. However, people thought it was more appropriate for people who really cared about the bill. So the bill sponsors thought, this is the type of evidence I need when I need to convince my colleagues to come onto this bill or to not support the bill. And so they were really thought that people who were vested in the proposed legislation would be ones who would be most interested in the level of detail we provided. We heard about a desire for cost-benefit analysis data, which isn't surprising to hear. We were intentional about not including cost data in this because when we did our pilot, we found out that there were so many other groups that were doing the cost analysis, and we thought, well, this is a way that we could fill a gap by focusing on health. But as we're moving forward with our work now to this day, we are thinking of how do we bring in some cost data, some of our own data, our analysis, to bring cost data into our health notes when there's not data available elsewhere. We also heard individuals, again, really talking about the value of having the scientific literature assessed and providing that information to individuals where they can go look at the evidence if they needed it. This is an important point because we learned during our pilot that I'm sure many people who particularly outside of academia have faced is that for a long time, a lot of the evidence was behind paywalls. So that was one barrier we heard from our partners as they were trying to do this on their own after we trained them was, we can't get to the data, right? We can't get these papers. Maybe Google Scholar might be a way to get it or looking for some other open access data sources. And this was why we thought having a close partnership with academia could be beneficial because we have access to a lot of these articles. And so for those individuals outside of academia who are doing this, and I'm thinking about a colleague at a health department in another state right now who's doing this work. They have a partnership with academia and they reach out when they need to, but they are relying on the fact that a lot more evidence is open access, although not all evidence is open access, so we acknowledge that as well. So they're hoping that through their academic partnership, they are truly getting access to all the relevant data. And finally, we heard it from our evaluation, the importance of timing. And one of the things that was really interesting is we heard a number of people say, this is great, and can we get it earlier when we're drafting the bill? You know, getting it after the bill is drafted to inform the hearing is helpful, but how do we get it earlier? So that's something to think about and would be key. Our relationships with the legislators would be key here to engage with them when they're drafting the bill. But acknowledging that part of the analysis is to be specific based on what we know is being proposed, so there's a little bit of a tension there. So we're trying to think about timing here a little bit differently as we move forward. Speaking of moving forward, so where are we today with this work? Well, I'm proud of our continued work on the legislative health notes. We continue to engage with policymakers and to promote this work. And one of the important points I want to lift up is around why it matters for policy engagement. We published a book a couple years ago through APHA Press on policy engagement, and we wrote this for really public health folks. As somebody who does policy, I often had individuals coming up and saying, well, how do you do policy? Where do I start? So we wrote this book with support from APHA Press as part of their strategic skills series about how to engage with policy. And this is not a shameless plug. It is a plug. No, I'm just kidding. No, seriously, just want to name, like, why I'm mentioning this is we talk about health in all policies in this book. Wrote the chapter on health equity and about how health in all policies is a tool, and we can use that to engage with legislators, particularly, again, in non-health sectors. And this book is written in a way, too, that's very accessible. The authors, all three of us on here, have deep experience in the policy process at the various levels, and we talk in here about why does policy matter, guiding principles for policy engagement, how to think about health equity, and the importance of not doing this work alone. And that's critical for the health note that I just mentioned. I stand here in front of you representing a team of people. We've also involved graduate students in our work. One of our students did an analysis, a health note for her capstone, for her master's degree. And so again, we're training people to use these tools. We're engaging with individuals and meeting the needs of policymakers through our policy engagement. And so I wanted to just unpack one of the sections in here on policy engagement, which I hope will leave you excited to think about how you can engage in this work in your own communities. And so in the book, we lay out these 5 principles to policy engagement. And again, all of this is really critical, I think, for the work that we're doing in to advance health in all policies. The first principle we laid out is that policymaking is messy. People talk about sausage and making sausage. It doesn't resonate with vegetarians, so we just talk about messy. And so we talk about it being messy, a little bit messy at times. And in terms of how policies move forward. And one of the things that I'll share is when we think about health in all policies, it's how do we understand the processes that our other sectors we're engaging with are moving forward through? How do we acknowledge and understand the messiness that they describe? We need to understand that to know when to engage, how to effectively engage in helping to inform health decisions. We also talk about how you engage is personal. I spend a lot of time engaging directly with policymakers. It's part of my values. It's part of something I'm interested in, I'm passionate about. But that's not for everybody. I acknowledge that. There might be ways that you want to engage in the policy process, but you're not the one who wants to go have those one-on-one conversations. Well, there's ways to engage by partnering with others, by working with intermediaries, by writing those op-eds. The goal here is just to think about how do you use your voice. If you're generating research, how do you translate that evidence to inform the process? So again, a number of ways, and we encourage you to think about how do you want to engage and what is important for you and your own values. We also talk about how lobbying is not a dirty word. I was told when I started this work, well, Keshia, you can't lobby. I'm like, we don't lobby, we are educating. We are involved in nonpartisan education and advocacy. And as public health individuals, I know sometimes we are afraid to even do that because of concerns about objectivity or being at a nonprofit institution. But we, I believe, have a responsibility to get our evidence and science into the hands of people who can do something with it. And that's what we talk about here. One of the other messages is around how do we actually get our science, our data, our findings to align with our key audiences. And this is really critical as we engage with other sectors. I'm thinking about some work we're doing right now on a bill that touches public safety. So we have to understand what are our colleagues, how do our colleagues in public safety talk about issues? We can't go in and say, here are the odds ratios and p-values that you should care about. That's not gonna work. So how do we take our science and translate it in a way that we know is going to make a difference and that will resonate with our partners? And finally, we talk about policymaking taking a village. I think one thing that's really important is that, especially in these times where it feels like the work we're doing is really hard, to remember that we are part of a broader community of people who have similar goals and values and a vision for the world. And I encourage you to find those people and to know that you don't need to do this work alone, that it truly takes a village, and that we can advance and achieve equity through the work of the collective work with community, and that we all are, again, part of a larger village. Brad, in his introduction, talked about the importance of the next generation, and I want to just acknowledge the work that we're doing with doctoral students across the country, and we've been doing since 2019 under my leadership, but since 2015. So I have the great privilege and honor of running the Health Policy Research Scholars Program, which is a national program of the Robert Wood Johnson Foundation. And part of this program, the vision here, is to connect with doctoral students. And I'm intentional in using doctoral students because it's PhD, but it's also that doctorate of nursing. It's also that doctorate of psychology. As long as you're in a research degree program, you apply to our program, and we've had cohorts of 40 people. We are actually in the process of interviewing and selecting for our 9th and final cohort, unfortunately. It's been a 15-year journey by the time it'll end. And what we've been doing is training up scholars, including, we have a scholar here actually at this institution who's part of our program as well, who applied to our program from across the country and the territories and are learning about health equity and learning about policy change and how to advance health equity from their discipline. We just published our first sort of overview paper of the Health Policy Research Scholars Program, and why it was so important to write this initial paper, and we have other ones we're working on, is that I believe that we can integrate a lot of what we do into every single doctoral program in this country. Because I acknowledge that our program is well-resourced, and it is challenging to say, well, go ahead and do what we did with these resources. But there are things that we can do in every single program, and it's about promoting interdisciplinary collaborations. It's about promoting working across sectors. It's about promoting centering community, promoting policy change. And so as we think about the work that we're doing to advance health through training the next generation of leaders, I also encourage all of you who touch education to think about how can you do that here? How can you do that actually to the individuals who are not here? We were talking earlier, Dean Sable Atwood and I, about who's learning about public health when they're in elementary school? Who's learning about health policy at that age? How are we engaging with the future leaders to help them know the tools and the possibility to create a world where they want to live in and where they can thrive? So I want to come to the end of my time, and I am right on time, which is great. And I want to just share a few conclusions as we wrap up our time together today. First is I hope that I've shared with you how using a health in all policies lens can make policies and decisions from other sectors more health and equity promoting and less harmful for health through tools like a legislative health note or even a health impact assessment. I also want you to know that I truly believe that health in all policies is a successful strategy to expand collaborations between health and non-health sectors. It gives us a framework to bring different sectors together, to get out of our silos and to partner together. And we have to be intentional here because it's so easy to stay in our lane. But I also think by staying in our lane, we're missing a lot of opportunity to connect with other people and to make a difference in this world. Framing matters. That's another point I want to leave you with today. And as we think about narrative and the narrative around health in all policies, one of the points that I hope you take away is part of the narrative needs to be working together, engaging these other sectors, particularly thinking about how non-health partners are health partners. Public health touches so many. And how can we be intentional about bringing these non-health partners to the table? I also want to remind you and leave you with this point that health in all policies can be useful for both policy formulation and implementation. So it's not enough to have that bill turn into legislation, but as we think about the decisions involved with implementing that piece of legislation, there are ways to bring this framework to bear as well. So again, we can think about health in all policies throughout the policy process. And finally, you, we, all of us, I believe, have a role in policy if interested, and I encourage you to seek opportunities to build capacity and to engage with community, engage with your partners, engage with this community in this room and elsewhere to help to change policy at the local, state, and federal levels and to lift up health in all policies. So I want to just end with this quote from Representative Clyburn, and I actually wanted to end with this because I do remember when you said this. I don't know if you remember. It was in 2020. It was at a House subcommittee meeting where one of the hearings related to COVID, and you said public health is not a partisan issue. I also want to say that health equity should not be a partisan issue. We all deserve I believe that we all deserve to be as healthy as possible. And health equity is possible to achieve, regardless of where you live, where you were born, the color of your skin, the language you speak, who you voted for. All of it is possible, and we all deserve that. So I invite you to continue to stay excited about advancing health equity. I love that this seminar, that this day is happening. And I encourage you to keep going out there and promoting health equity because we can achieve health equity for every single person so that everyone everywhere can be as healthy as they can possibly be. So thank you for your time today.